Thanks, John, and thanks to the MD Expo for putting this on. I mean, I assume that by a raise of hands, how many of you are hospital-based employees? Okay, and how many are independent service organizations of some type, or in any other groups, maybe regulatory or okay? Well, it's a valuable thing for the community across the board. Anyway, I'm Dustin Telford, and I'm joined by Barb Malanga, or Malanga. Occasionally I get it wrong. Barb Malanga. We both work for the Device Safety Consulting Group with ECRI. If you're unfamiliar with ECRI, we'll talk a little bit about what we do at ECRI. But one of the taglines I grew up with ECRI before joining about 2 years ago was that we're consumer reports for medical equipment. We also happen to have a high level of expertise in other patient safety areas and direct focus, if you're not familiar with this, with biomed or HTM. Today, we're going to talk about evaluating service delivery models. We'll go through kind of what that means in more detail. But one of the things I'd like to do first is I'd like to kind of get just kind of a poll of the audience other than what I just took and see how many of you have had the decision, struggled with the decision about whether or not to put a device on contract or keep it on contract versus say another option in say the last year. So how many of you, by a raise of hands, have had this difficult decision in the last year of whether or not to contract a device out for service or keep it in-house? And for those ISO folks out there, how many of you had that difficult decision about whether or not to pass through to say somebody else that is an expert? I see a nod at least. I'll take that as a hand. That's why I wanted to kind of ask who all you were. But today we're going to address those difficult decisions. We're going to show you some methodology and give you some tools at the end of this that you can use to apply for making those small decisions on one item of equipment to larger scale decisions. And we, as ECRI, will give you an agnostic viewpoint, right? We don't provide service, we don't provide contracts, but what we do try to help healthcare organizations primarily do is make smart decisions about where their money can be best spent and, of course, the safety issues. Barb?
All right, so when it comes to service delivery models, you kind of have three choices. You can go in-house, you can outsource to an ISO or an OEM, or you can do what we call hybrid. The question is not which model is the best, it's which model fits your situation, your equipment, your organization, your team. So today we give you some tools to answer the question with evidence. Before we get into the different delivery models, let us establish the full scope of what a strong HTM department typically does. So obviously it's responsible for maintenance and repair of medical equipment, but it doesn't really stop there. HTM staff also play a pretty critical role in asset management and safety and compliance and technology planning, and the list goes on, cybersecurity, training and education, incident investigations, vendor management, and they're expected to optimize finances.
So on the, Barb kind of illustrated 9 boxes, if you got this, 9 boxes where a health delivery organization primarily has to provide some sort of HTM functions. To distinguish, it doesn't necessarily need to be an in-house program. We're not talking about that as the only solution. We're talking about all those 9 boxes though. So remember, it's not just about break fix or the maintenance and the inventory. We're talking about all those services when we're evaluating what service models might be good choices. Trying to get my slides to advance here. So Well,
No, no.
oh, sorry, go ahead. This is you.
If you do outsource, the functions that HTM usually handles don't disappear. They either get handled, they get paid for separately, or they don't get done.
Sorry, it was a little off on my slides and this headset's bugging me. Sorry about that, folks. Especially those online folks that don't know what I'm talking about. So we're going to talk about, first of all, when you are making a decision about what we mean by service provider or service model. Most of you are probably familiar with the OEM. I hope at least you're familiar with the OEM. They sold you the device, they know it, right? Or at least in theory, they know it very well. Now, here's where it gets a little gray. It's a matter of how you call it. Multi-vendor service is essentially the same as independent service organization. Multi-vendor, though, is a name that some OEMs have coined, if you will, for they also provide services on somebody else's equipment, right? But essentially, those are the same. My point to provide is that here is that no one vendor necessarily and provide all scopes of services. And we're going to kind of talk about what that means, those 9 boxes. So keep that in your mind. For most hospitals, no single model works for everything. Hybrid is not a compromise, but we're going to talk about hybrid. And the reason why will hopefully become very evident in the next couple of slides. Again, 9 boxes. You need to provide those services like cybersecurity. If you have an ISO, that ISO may provide cybersecurity on some devices or be able to do a very good job on others. But what it may be missing is when you're evaluating either at the equipment level or maybe your entire department, if you're a healthcare organization, whether or not you contract, whether or not you come up with a hybrid, is the gaps. What are you missing? What are you not getting necessarily, either from your in-house program, your outsourced program, or whatever, and how you complement these things, potentially with what we're going to call hybrid. There's no one formula for identifying what service model is ideal in every situation, but some factors to consider are things like the cost to maintain the equipment, how it has the greatest, if it has the greatest impact to outsource, in-source, or something else. This we're going to talk about in detail a little bit when we talk about what your response times are to deliver on service, to finish service, and if you have access to certain things like parts. And right here, like what your costs of downtime are. What are the costs that the clinical side is going to experience if your, say, in-house pilot team doesn't meet their service level agreements with the organization? Your strongest negotiating position usually is to negotiate certain terms up front when you acquire the device. And to illustrate this point, I'm not talking about point of sale agreements. Sometimes those are a good thing. But to negotiate up front what you plan to do in the future with that particular equipment that you may, say, transition in-house. You may transition or hand off to an independent service organization that's not the original equipment manufacturer. Later, after this session, there's going to be a discussion about right to repair. We do know that there are sometimes restrictions that handcuff an independent service organization or an in-house department. And so we want to talk clearly about your strongest position as a healthcare organization is likely to start here and be the best time to have those conversations with the OEM about how they are going to provide support to whatever model you eventually want to address. And we're going to talk about the tools. So we're going to follow a checklist of qualifying what that should look like: price, capability, response time, et cetera.
Shown here are 10 factors to consider when choosing a service delivery model. We're going to use these to go through a working example of a fluoro system that's coming off warranty. And at the end, you're going to get a QR code that has a handout. And the handout has a lot more detail sort of on each of these factors. We're going to focus really in on the ones that in our example made the biggest difference, so became drivers for the decision. So our example is a fluoro system coming off of its 1-year warranty. Your options are going to be full in-house, full ISO, I'm sorry, full in-house, full OEM, full ISO, or some kind of hybrid using demand contracts. We're going to put numbers next to each of these options. Here's the decision matrix with the 5 service options listed in the columns at the top. And the first of the 10 considerations is scope of service or service scope. In-house, OEM, and ISO all offer full service for this example. The demand options are time and material. You call them when you need them, you pay per event. For hybrid, think of service in 3 tiers: routine IPMs, first looks, and full repairs. The question is which tiers your team handles and which ones you outsource. The more your team takes on, the less the contract needs to cover, and usually the lower the cost. So what determines the right service scope for a particular piece of equipment? Well, 4 things. First, how critical is the device? What happens if it fails? Second, do you have a backup? This is your only fluoro room. The calculus is different than if you have 3. Third, what are the consequences of downtime? Not just clinically, but financially. A dark imaging room is lost revenue. And the fourth, does your in-house team have the competency and bandwidth to handle the full scope? All 3 tiers. Do you need support with some of them? These 4 questions apply to every equipment in your category, not just the example of the fluoro system we're using today. The second consideration in our matrix is cost. In our example, the in-house model is the most cost-effective at $15,700 per year. The ISO full service option falls in the middle at $19,000, and the OEM full service option is the highest at $22,850. Cost is one of the considerations, showing significant differences between the 3 service models, as it will be in most decisions. So it will definitely be part of your final selection criteria.
Total costs are deceptive. There are hidden costs in total costs of service. Barb illustrated what was covered at a very high level. One is assumed to need a replacement occasionally for the in-house model. And if we went back to that slide, you'd see that 2 tubes were covered, say for the OEM, and no tubes may have been covered for the ISO, if I recall correctly. However, there are hidden costs to what's in those 9 boxes that may not be covered. We're talking about an individual piece of equipment, so it's unlikely that you will have things like life cycle planning or financial stewardship, right? Or financial optimization of some type at all. You may have some advancements in cybersecurity or whatever, or some assurances in cybersecurity, but those are true costs. Those are costs that will exceed your expectations on just that line that we just showed, as far as how much it's going to cost you for what you assume is the maintenance of the equipment. So I'm going to talk a little bit about, and to this audience, I'm sure you're familiar with the term COSR, but if you're not, it's the cost of service ratio for servicing, usually to service all medical equipment, but we're going to take it at this level here. What's the cost of service ratio? And that is the numerator over the denominator. The denominator is pretty easy to figure out if you know the value of the equipment. I'm not talking about the current value, not a depreciated value, what you initially acquired the piece of equipment at. But I don't know if I just messed that up, but the denominator is that, the numerator is the cost of service. What oftentimes gets confused here is that an organization may say, well, I'm only paying this much for service, so that's my cost of service. Your cost of service needs to include the things that are possibly hidden, not on the paper, but you know about as a healthcare delivery organization that you want your HTM services to provide. They might be the labor and benefits. Somebody's going to have to walk that vendor around, or somebody's going to have to make sure the vendor does their work. Somebody's going to have to accept the paperwork from the vendor. Those are all costs to the healthcare organization. It's usually left to, say, somebody, if it's managed one piece or whatever, or several pieces of equipment from an in-house department, it's left to the technicians or the manager or somebody that's intaking these documents, but it's still time. There are other things like some of the tools, parts, and supplies might not be included in there, right? And I say that because this is something that an in-house program needs to take into account, is do you have the tools to do the job? It's absorbed relatively by the ISOs or the OEMs. So the important part is your COSR should be your entire HTM cost, all those 9 boxes, not just the inventory management and the maintenance management. So an asset COSR is just at that individual level. I'm going to make a distinction here, and I'm going to say that if you're not thinking about it yet, since I just mentioned COSR is total cost, RME percentage or repair and maintenance expenses percentage is just the maintenance cost. That's usually what the benchmarking solutions, that's usually what you'll see published, is COSR as the cost, the known cost of what it takes to service an individual piece of equipment. There is a distinction, it varies. And the reason why is because those hidden costs aren't in there. It's just the repair and maintenance costs. Think of it in those terms. It may include something else or whatever, but it's not all 9 boxes. The confusion happens when the contract price is used as a total cost in the numerator, and then you have your original equipment costs. Again, that's the same denominator as in the previous. Program level outsourcing, usually, if you're outsourcing this, you want to make sure that you hit all those 9 boxes, if it's multi-vendor or ISO. But if it's not covered here in your individual contract for individual pieces of equipment, or for your program that you're delivering to a healthcare system, it's either a hidden cost that you're going to pay for somebody else to do the work, or it's not covered at all, and you run the risk then of some detriment to the organization, such as not responding to an incident appropriately or recall management on that equipment. Next slide, please.
Do you want to go through the example?
Oh yeah, I'll illustrate this example here. So in this example, just to kind of put some numbers to it, the maintenance only cost, the RME percentage, in our example for fluoro, would be 32, not on the fluoro device that we saw before, but at 32,250 for the acquisition value of 35,000. The RME percentage is 9.5. That's not the actual COSR. COSR in this example, if it's an individual piece of equipment, might be 10%. But you've got to know what that cost is. The 10% comes in with, say, your HTM department staff has to manage incidents, manage the vendor, manage the paperwork, and manage the compliance risks internally. So here are some of the COSR benchmarks. This is mine, I hope. Mm-hmm. Okay. Here are some of the COSR benchmarks just to kind of drill a little bit further into this a little bit. In-house, good in-house program. It's been published several times that a good in-house program, even by ECRI, is about 4 to 6%. An ISO may average 6 to 10%, and an OEM is almost certainly and almost always 12 to 20%. We see some outliers sometimes. We actually see some manufacturers just for maintenance costs that are 30%, right? Those are extreme situations. They're unusual, but 12 to 20% is the published assessment of the kosher environment. But remember, this is wrong because it's only looking at contract costs. It's only looking at the service costs if you consider your in-house team a contracted service. You should. You're a business. It's only taken into account the maintenance costs only.
So it's really an RME.
So it's an RME. Yes, thank you. Just keep that in mind as we talk about it. It doesn't make as much of a difference on individual items, but it does make a difference, whatever your business model. If you're an independent service organization, you're going to have to take into account, do you pay somebody else to do this or are you doing it? Just like an in-house department would on the aggregated amount, say doing a full HTM scope of service.
Now let's move on to the third consideration in our matrix, that's staffing and competency. The matrix shows significant differences in staffing. In-house has 3 BMETs on site. The OEM is offering 4 techs, but they're 55 miles away, and the ISO is closer at 10 miles. And on competency, apply the same rigor to outsourced personnel as you would to your own staff. Ask for documented proof of training, call references, and ask for specifically about the technicians who will be assigned to your account. For in-house, honestly, assess whether your team has the competency for the specific equipment. If they need training, factor that cost in and consider a hybrid model with demand back up until they're up to speed. Response time goes hand in hand with staffing. In our example, in-house responds in 20 minutes, the OEM takes 4 hours, and that matters when your floor room is dark and patients are being diverted. The impact of that depends on criticality of that device, that backup availability, and revenue consequences. But frankly, unless the OEM or ISO embeds personnel at your facility, in-house will always kind of have the response time advantage. Require guaranteed response times in every contract, especially for demand service where vendors prioritize their contracted customers.
So in this scenario, one of the things that needs to be considered is access and availability to tools. We deliberately picked the floral room, also do a little education on something else that commonly gets misconceived. But I'm going to point out that these are all about equal, more or less. The in-house program and the ISO should be able to support the device under contract, and I'm going to carve out how and why. Just as well as the OEM, one would say initially on paper. The OEM, obviously, they have the manuals. They hopefully have the trainers to train directly their employees to do the service, and they're going to know about any field updates, et cetera. But in the case that we bring up with fluoro, there's often a misconception that manufacturers do not need to provide service literature for any devices. That's not true specifically for radiation emitting devices. In our case, ionizing radiation or X-ray rooms. Also linear accelerators for that matter, if you want to get into that business. But I will say that this is limited. HII-Tech on our screen stands for, and again, you'll get these slides if you'd like them, and you'll get a bunch of documentation if you scan the QR code. HII-Tech stands for Assembly, Installation, Adjustment, and Testing. essentially, in order to comply with the FDA, OEMs must provide at a reasonable cost to anybody who requests it, right? Joe Schmo, who doesn't even service medical equipment, can ask for this information from the manufacturer, but specifically the ISO and the HTM department. But it is limited. I say this because my experience is start with asking for the service manuals, the full service manuals. If the manufacturer is unwilling to do that, or they say unable to do that, point out that they are responsible for these categories: assembly, how you put a part in; installation, how you put those parts together, right? Adjustment, any tweaking or whatever that might go on, even in a PM; and the testing, right? The testing, again, is an element of what you would need to know to support the equipment in-house. Just doesn't have to be a full service manual. The reason we wanted to bring that particular example up, as opposed to maybe a more dry example, is we know that ISOs sometimes are more prohibited sometimes by the manufacturers because they see it as competitive. We talked about multi-vendor service providers. They are in direct competition with you if you're in an in-house program, but also with the ISO to earn your business if you're a healthcare delivery organization. So I'll move on to the next point, but it's interesting to illustrate that their capabilities are about the same, but one other caveat: manufacturers do not have to provide parts to any of these folks. The in-house department and the ISO, maybe you're restricted on the access to the actual parts to provide some repair or preventative maintenance. That's where it gets a little sticky. Next slide. We wanted to talk a little bit about one of the other factors to consider, and that is contract terms for outsourced service. In our illustration, we're assuming this is a typical, say, HTM department, in-house HTM department, runs maybe 8 to 6 or 7 to 3:30 or whatever, right? But you have on-call built in, and you have essentially an uptime guarantee, because somebody's going to complain if Biomed did not perform the service, of about 90%. We really want to focus here on the comparison between the OEM and ISO in this example, though. OEM, ISO, essentially the same hours of coverage. This is a great contract, by the way, because we said 5 p.m. to 12 a.m. and around for outside of service hours. It's pretty good contract mix. But if you notice, the OEM's guaranteeing 95% uptime. And the ISO 90%. The difference, say, for 2,000 hours of operating time for this fluoro system a year, right? If you're only calculating those business hours that are covered under the contract. In 2,000 hours, that can amount to a difference of about 100 hours, 200 hours of uptime or downtime allowed for the ISO, 100 hours for the OEM. What we didn't really illustrate, and we kind of hid this to illustrate this, is one of the considerations here is this is a new system just barely coming off a warranty. We did mention it, but you may not have caught it, but it's a brand new system. It's coming off a warranty. So a guarantee of 90% really isn't a bad guarantee. It may be a little conservative from the ISO to say we only guarantee 90%. The OEM already knows it's pretty much going to be just fine because it's in that first year where it's unlikely to need major service events. On uptime guarantees and downtime penalties, make sure that you have guarantees built into your contract with anybody that you contract your services to about what their guarantees are, and not just on an annual basis. I gave you the example of 200 hours a year and 100 hours a year or whatever. But nobody wants to have their system down for 200 hours, or 100 hours in a week. Look for weekly guarantees. What this means in the contract examples here is the OEM's guaranteed that they'll credit next year. So certainly a good model in a way. It keeps the OEM in your program because they've said, well, we're going to give you some money back so we can keep earning money. The ISO here has illustrated that they'll give you a 5% rebate on the current year's labor charges, right? This may make a difference in how you assess whether or not you are going to stick with the OEM or you plan to eventually move away from an OEM or an ISO. But make sure that you have both, at least one of these or both, an uptime guarantee or a downtime penalty. Having the penalty, unfortunately, we'd all like to think that we could do the positive reinforcement with our vendors, just like we do, like I have a dog. But they're probably not going to be they're not going to be wagging their tail if you give them a bone every once in a while. You probably need to put a financial penalty in there.
Number 7 in our matrix is vendor qualifications. Always obtain a client reference list, call references, and ask about the specific technicians who will be assigned to your account. Service quality can vary from a given vendor dramatically by region and by individual. And here's the question we keep coming back to. When you outsource maintenance, who handles those other HTM functions? You know, all the ones in the house.
Yeah, this is where Barb and I get back to those 9 boxes. If you're fully outsourcing, you need to consider, again, what's not covered in your outsource plan or your in-source plan from an HTM perspective, and what is covered. If one or more of these are not covered, you're either going to pay somebody else to do it, or it's not going to be covered at all, and you'll run a risk in areas like cybersecurity, possibly training and education for your staff and the clinical staff, and things like technology planning or acquisition. These are essential building blocks of any good house or HTM delivery service model. Not everybody has all of these, but remember, you run the risk if you don't find a solution. You pay for it or you do it internally. If you're not doing it at all, you run the risk of not demonstrating value to your organization and hopefully, as we are ECRI, improving the lives of patients.
So with our example, we identified 7 areas where there were significant differences: cost, competency, response time, access to diagnostics, uptime, access to OEM support, and access to materials. The first differentiator was cost. The OEM full service is $7,000 more than the in-house estimate. But this fluoro system is only in its 2nd year, so major failures and repair costs are unlikely. And this particular system has a strong reliability track record. So the risk of exceeding the in-house estimate is low. So based on cost alone, the full service OEM option can probably be eliminated. The ISO full service option is only $3,000 more than the in-house, but its access to software and parts seems to be constrained by the OEM. Since in-house is already less expensive, there's no reason to accept the risk of compromised service at a higher price. The full service ISO option can be ruled out as well. So our conclusion is, whoops, went too far. So our conclusion is go hybrid for the first 1 to 2 years, transitioning to a full in-house when the technician gains experience.
And then think about your transition. OEM demand backup or ISO demand backup support while you're building capabilities in your own department may be a solution for an in-house program. Same thing for an ISO for that matter. I've worked with ISOs or multi-vendor, and we've built up our team. It's perfectly acceptable to take on a little bit of risk, right? Learn the ropes, do the PMs, et cetera, and then call upon the experts who have a better level of expertise to do the other work, the more difficult work. Next slide, please.
Well, we walked through this example for like an individual piece of equipment, but you can apply the same processes to like your entire program. Nobody runs a pure in-house on everything. Nobody should run pure outsourced either. The real question is, to what extent do you hybridize? And for which categories? The methodology gives you the framework to answer that.
So I'm going to give you an example here. By the way, my notes died on me, so anyway, I'm going to give you an example here of a 400-bed community hospital with a strong HTM program. This particular program has sorry, didn't mean to yell there, has 8 BMETs, low turnover, very seasoned personnel in general, and they have 3 imaging personnel that are cross-trained. They have a standardized fleet. It's relatively easy to work on because they don't have, say, technicians trying to figure out what's what from department to department. Their in-house closer is 3.8%. All the OEM quotes coming back to them are about 14%, say on average. A $20 million equipment inventory to go fully outsourced in this example would mean a difference of about $760K versus the OEM outsourced solution of about 2.8. If that's not a selling point already to say, well, why don't we start training our in-house technicians to do the work, or finding maybe another solution or a better quote, it's a good time to do it. Again, we've already illustrated, usually unless the OEM or the ISO embeds personnel in your organization, if it's outsourced, they probably will, or they'll probably embed some of their personnel. Response time for an in-house person, an on-site person, is much, much faster. Now, the imaging example might be the exception. You may not have enough imaging workload for an imaging engineer to always be at that particular hospital, but the size of this hospital probably would, for a good, well-rounded imaging person, or 3 in this case. You also achieve, if you stay in-house, you obtain full asset ownership of data, recall tracking, and even lifecycle planning. One thing that I will pause here on is, remember, if you have a manufacturer agreement, a multi-vendor service agreement, there may be an influence for them to suggest that you replace equipment with their equipment that they happen to sell. Not always the case, but trust but verify. There may be something better for your clinicians to use in an organization than the one that they happen to sell.
So when is outsourced service the clear choice? Outsourced wins when your in-house capabilities do not cover the need. This is a 3-hospital system with an understaffed department, far from an OEM hub and a nearby ISO that offers a comprehensive program, including capital planning and accreditation support, and the ISO's proximity and track record make it the best available option.
If I have something, let me know. Sorry. Oh, hybrid wins when you apply this methodology. Oh, sorry, I didn't say that. Hybrid's the clear choice when you apply this methodology. Per category of equipment is a good opportunity. Surgical equipment, you may perform in-house, or you may decide that there's a specialized need such as anesthesia, for example, that might be better served directly by the OEM or by a more qualified independent service organization. Clinics are almost certainly going to be outsourced, not usually done at all by an in-house team, and usually to the OEM, but not always. There are some categories like robotics. I think we may have it up there, but I've got it in my notes. Robotics, that up until about 2 weeks ago, I didn't know that there was another solution possibly to providing services on robots, on surgical robots. The case is almost no one can claim that they're fully in-house or fully outsourced. There's probably a hybrid somewhere in there. Whether or not they have somebody managing the independent service organization's actions and delivery, or they are individually scoping out, say, the surgical robots. It's a hybrid. Next slide.
So we covered a lot of ground, and we're going to give you a handout that has a lot of details. We'll have the comparison matrix we showed you, the pros and cons for each service model, the COSR calculation worksheet, and a vendor evaluation checklist. So scan the QR code on the next slide to download everything. The single biggest takeaway, this is your decision, not your CFO's, not your vendors. You have the technical knowledge and cost functional perspective. The comparison matrix will give you the way to document your evaluation so it's defensible to anyone who might ask. If you do one thing differently, the next time a piece of equipment comes off warranty, pull out that matrix and run the analysis before you just come up with the default answer of whatever you did last time. You may make the same decision, but now you'll have the evidence to explain why. Thanks, and we do have some time for questions. There's the QR code.
So there's the QR code. I would, if you've attended our other sessions, we've had a couple of materials. This one actually has quite a few useful little tools. Let us know if you adapt them or whatever. If you have a tweak or adjustment, it'd be great to get that feedback. You can connect with me and Barb, book some time with us. We can talk through things that you're thinking about or whatever. We want to get your feedback, which is a good introduction to this. If you're not familiar with us at ECRI, we are here to hopefully support the HTM community. Barb and I have recently accepted certain responsibilities for updating Biomed Guide. It's a service that maybe some of you have. We're looking to really make it even better than it is. Biomed Guide offers some benchmarking, useful life, contract service analysis, but I can tell you that we are excited to hopefully get more of the HTM community's involvement and say, what do you need, right? We happen to be talking to a customer tomorrow who's in this area of ours to get some feedback. What do you really need from ECRI to support the HTM community? But hopefully these are helpful, but the only way these become even more helpful is if you give us a little bit of feedback and say, that COSR calculation worksheet, you should put it in a formula to do this or whatever.
So, are there any questions?
I'm surprised a bit that there's no questions. We tried to remain agnostic in this case, but we're not advocating for one or the other, right? Yes.